Hi, good evening, everyone who's out there. Thank you for joining us. This is a webinar sponsored by the American Shoulder and Elbow Society through the Research Committee. Our topic tonight is to explore how we might establish biospecimen repositories for our research studies. Our clinical research studies, typically we obtain patient-reported outcome measures and imaging studies, physical exam when we can, but I think we can improve our clinical research by procuring and analyzing specimens from our patients, either specimens of pathologic tissue, say you're doing a rotator cuff repair, you have a sample of abnormal tendon, or specimens that allow us to phenotype our patients, which may eventually allow more of a precision medicine approach, if you will, to our patients. So tonight we have three talks from experts in this area who will give us some tips and pointers and share their experience on collecting, processing, storing, and analyzing specimens from our patients, both surgical as well as non-surgical. So I want to first thank Smith & Nephew for their support for this webinar series. We'll have a brief video and then we'll jump right in.
Good evening, everyone, and welcome to the ASCS Foundation webinar series. I'm Scott Gunn, Vice President of Shoulder Marketing and Sales at Smith & Nephew. As the sole sponsors of this series, we're thrilled to have the opportunity to introduce you to Smith & Nephew and our innovative product portfolio. For over 100 years, Smith & Nephew has been at the forefront of medical technology, committed to improving lives through our pioneering solutions. We're excited to share our latest advancements in shoulder arthroplasty and sports medicine. Our team of experts have been focused on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the elegant ATOS shoulder system, which embodies stability, simplicity, and flexibility. ATOS is a streamlined system for both anatomic and reverse procedures, allowing for an elevated operating room experience. Throughout this webinar series, you'll hear from leading experts in the field who will discuss the latest research, clinical evidence, and best practices in shoulder and elbow medicine. Thank you for joining today, and we look forward to sharing our passion for innovation and helping you provide the best possible care for your patients.
Great. Well, we thank our sponsors. We appreciate their support here. So we have three brief talks we'll go through, and then we'll have some time for discussion. So I'd like to introduce first my colleague at Special Surgery, Miguel Otero. Miguel is Associate Scientist in the Orthopedic Soft Tissue Research Program, and Miguel directs our Molecular Histopathology Core Laboratory and also serves as co-director of our Precision Medicine Lab, as well as our Institute for Histopathology Services. Miguel will talk to us on biorepositories to enable a precision medicine approach in orthopedics. Miguel, thank you.
Thank you. Thanks for inviting me. So let me see if I can share. Can you see my screen?
Yeah.
Yep, got it.
Oh, perfect. So thanks so much for the invitation. And what I thought I should do is maybe give a brief overview of the type of approaches that we are taking at HSS, trying to use and develop biorepositories as enabling tools for precision medicine for orthopedics. These are my disclosures, nothing really relevant to this talk, but I would like to acknowledge the funding, different funding sources that we use to develop those repositories. And I thought I should start by something like pretty obvious, right? That building a biorepository truly is a team effort. It requires a lot of coordination and a lot of synergism between different departments. I'm highlighting here a number of individuals who are key in different repositories at HSS, some familiar faces like Dr. Scott Rodio that you see there. But it really is an integration of the rheumatology, orthopedic departments with the Department of Pathology, and then a lot of the research laboratories that they are kind of working on processing samples, collecting data, storing biospecimens, and then conducting analysis. And I didn't list everybody. Obviously, it truly takes a village, but we work with Clinical Research Administration, with our legal department, with finances to address all the compliance issues as well. So why do we care about precision medicine, particularly for orthopedics? So I'm sure that you all know about this type of image discussing precision medicine approaches. And the idea is that optimal responses to a given treatment are driven by both patient intrinsic and treatment specific factors. And the main idea of the precision medicine tools is to really identify or understand the complexity within a given patient population, so we can understand patient specific factors. We can also study treatment specific characteristics, integrate all that information, and then separate the complexity of the patient population into different patient subtypes, phenotypes, or endotypes, depending on what we are talking about, so we can then start allocating treatment and predicting responses. So the idea is to deliver the right treatment at the right time for the right patient. And that's very important. It has been very prevalent for the cancer field, for example, but is becoming more and more important in other fields like rheumatology and orthopedics. So I thought I should show you an example of the type of patient-specific analysis that the biorepositories can enable, because I think two of the presentations today are going to focus on samples and orthobiologics, right? More on the treatment component. So we can use osteoarthritis as an example of a complex and heterogeneous disease. Osteoarthritis is complex because is in a sense, well, aside from being the most common form of arthritis and a main cause of pain and disability worldwide, so it's actually very easy to emphasize osteoarthritis as a main disease and a disease that we should focus on. It's a very complex disease in that there are a lot of different risk factors: old aging, obesity or adiposity, trauma, genetic components, you name it, and they all seem to contribute to the development of osteoarthritis. And then within patients with osteoarthritis, there are a lot of heterogeneity in terms of the affectation of the different joint tissues, right? So the osteoarthritis is truly like one diagnosis, but it's likely comprised by multiple endotypes or multiple molecular mechanisms driving the disease and leading to specific phenotypes. And that complicates the development of non-surgical treatments, right? The one-size-fits-all approach for treatment doesn't work in osteoarthritis. So we decided to use osteoarthritis and focus on osteoarthritis to try to develop some tools to understand the disease, right? And for that reason, we started thinking about tissue collections, data collections, or biorepository formation. So when we think about biorepositories as tools to enable precision medicine, even though this applies to every type of biorepository or biobanking initiative, we first start thinking about the patient population. What's the patient that we try to study, or the patient population that we try to study in terms of how representative it is from a given pathology, and how well we can curate the diagnosis, right? We also need to think about collection of clinical or phenotypic data, and I'll discuss some questions about safety, privacy, and how comprehensive that database should be to be able to understand the pathology, and then focus a lot on biospecimen collection, from the infrastructure component, development of protocols and whatnot, but also safety considerations, how you need to maintain data integrity and de-identify those specimens, but at the same time, make them so that you can link them to clinical data sets. And finally, I'm going to show you one example of the type of analysis and integration that we can do with this type of sample paired with clinical data sets, and the type of pipelines that we can develop with current techniques. So one of the first things that we started thinking about when we start developing this type of biorepository were questions of governance, right? We need to take into account legal and ethical oversight considerations for a biorepository. We need to take into account who will have access to samples and data, and how transparent that access and kind of repository needs to be within the institution, or if you open it to the overall research community across institutions. We thought about questions of quality controls and standardization. It is very important to harmonize protocols so you can compare different data sets collected at different institutions or between different diseases, and then data linkage. We deal with de-identified data for the most part, but we actually need to be able to go back to the clinical data sets to be able to connect it with clinically relevant information. So there are a number of best practice reference books and manuals that people can use for biorepositories. So when it comes to the patients, then it's a question of defining the patient population. You need to define the criteria, inclusion, exclusion criteria, have a well-curated patient population so you can then start making kind of a really robust analysis. Otherwise, if you include a lot of noise in your patient population, it becomes very noisy. And there is a limitation in terms of how many patients you can enroll within relatively small biorepositories unless you kind of are dealing with nationwide biobanks. For that, it's important to have screening tools. At HSS, we've been relying on EPIC for as a way of identifying patients who meet specific inclusion criteria, don't meet exclusion criteria, so we can then communicate with them. It is important, and this is pretty naive, I assume, but it's important to have clear communication within the team, between clinicians and laboratory staff, but also with the patients, right? So you can engage patients and have them be part of the study. And then it comes the question of consenting. Consenting, and when you are developing the consent, it's a question of keeping track of or keeping in mind the scope of the study that you are dealing. Be very explicit that the consent is voluntary, right? The patient should be engaged in the study and give tissues without feeling pressure to participate. Keep in mind secondary research. The idea with biorepositories is that they enable different type of research, so not necessarily a primary question, but also a lot of secondary research, and then address data privacy risks and benefits. And then it comes the question of data capture, how you deal with clinical data capture and storage, right? So it's a question of planning in advance, in that the data capture should be general. You need to capture a lot of demographics and phenotypic information, but also study specific, right? The questionnaires and forms that a patient with osteoarthritis will have, knee osteoarthritis will have to fill are very different than a patient that has some other pathology. So keep that in mind when it comes to develop databases. That clinical data capture should be connected with biospecimen capture and other potential biobanks or databases that you have institutionally, and if possible, make it longitudinal so you can follow patients over time if the patient consents and if it's appropriate for the disease, and all that should be supported by a robust data dictionary. So there is no ambiguity in what you are comparing, and there's no ambiguity in the analysis that you are conducting. And similar considerations for data storage, right? It's important to select a good electronic data capture platform. A lot of people are using RedCap. HSS is also using RedCap to keep data, but the question is that it has to be safe, secure, allow for control access, and it should retain data integrity while maintaining the ability of integrating data with other data sets. And when it comes to then biospecimens or sample collection, one of the first considerations is infrastructure, which usually is also a question of money and resources, right? So it's important to have good infrastructure and good tools for sample retrieval and transport. Staff should be fully trained in how to manage and transport those samples, and then have infrastructure to maintain those samples for the long term. So they need to be in a temperature control environment that goes from 4-degree fridge to liquid nitrogens, and ideally with real-time monitoring. So alarms, because you don't want to show up one day and find that your samples get ruined just because one freezer malfunctioned and you didn't know that. So an example of that is what we use at HSS. Is called -80 monitoring, but there are many companies that provide that type of resources and ability. And the other thing is when you're collecting samples, biospecimens, and you want them to be kind of useful for clinically relevant questions, is that they need to kind of be fully tracked. So that there are a number of different biobanking softwares, or some people decide to use Excel files or RedCap, for example, for sample tracking, which is fine. But the question is to use a system that is robust, that is secure and compliant. It allows you to have data integrity, but also a data audit trail if needed, that is user-friendly or transferable. People leave and you want the data to remain and the samples to be accessible to other people. In our case, we tend to work with de-identified samples with an alphanumeric code that we can then connect with clinical data sets. So we use specific software, like a cloud-based software for that. It's called Open-Specimen. I'm showing you here a quick example for that. This will be the dashboard that you get in Open-Specimen. So basically, you can track protocol progress and report. So you can see the samples or patients enrolled on a given time. This is quarterly, for example, report. And then you can break the collection into aliquots per sample type, how many aliquots are preparing, primary samples versus aliquots that they are going to be used, and then the specimens collected per tissue type. So this, in a sense, gives you like a overview of progress, and then you can get into location or sample-specific information. Open Specimen allows you to track the location of the samples, which freezer that the samples are in, the type of sample, how many aliquots you have, usage, and shipments. So in this example, this will be kind of what you see in a -80 freezer within Open Specimen. You can go to the freezer and then open shelves, right? Within shelves, you have 6 racks, and then within 6 racks, you can go and look within the boxes, right? And then when you go within the boxes, you can look specific samples, how many aliquots of each sample or patient were collected, and the usage, right? Whether the sample was used, the reason for the sample to be there or not, any type of deviation. So we find it useful, though, the user-friendly component in this type of software is relative, right? It takes a lot of effort to train people and have the system going. And then we go to the actual biospecimens. What you do when you really start collecting biospecimens, right? I'm summarizing the whole process, but what we think is important is to have fully trained staff and make sure that you transfer knowledge, so the protocols don't get kind of lost and that they don't vary over time. That you optimize things in a sample and analysis specific manner. So different samples will require different protocols, and within the same sample, different analysis will require also different protocols. So it's important to optimize both aspects. Enable secondary research by collecting samples that you can use for different purposes, and then, if possible, perform QCs, right? The samples are being frozen for a long time. You want to make sure that they are not being damaged or ruined, right? So that when you're running experiments, you know that you can rely on them. And then link data sets within biospecimens and between biospecimen and clinical data sets. So this is, in a sense, the full process from enrollment to processing and storage. In our case, in this example, we tend to collect tissues from the joint. They get transported and selected to directly in pathology. We work with our pathology department. And then out of each sample that the pathologists are selecting for analysis, we tend to make different aliquots. We collect samples for formalin fixation and paraffin embedding. So for histology, or in our case, for spatial transcriptomics analysis, RNA later for RNA isolation and RNA sequencing, or cryostore for viable preservation of the tissues, and then cell isolation and single cell analysis. Each sample type will have different storage conditions. FFP, for example, can be stored at room temperature, but we keep it at 4 degrees to prevent DNA or RNA damage. And then each sample has different QCs, right? So for RNA later, RNA, we look at integrity. If it's for paraffin, for spatial transcriptomics, we look at degradation by a different metric. It's called DB200, how many fragments are below 200 base pairs. And I identified or highlighted 2 critical steps, in my opinion. The first one is the coordination with OR for the optimal retrieval of the specimens to avoid that they get damaged. Sometimes they get burned. You don't want to have kind of a cauterized tissue that you cannot use. And also to avoid processing artifacts. The default in many hospitals is to put tissues in formalin right away. But when you use them for molecular analysis, you want them fresh, right? You want them in some sort of saline or PBS. And the other thing is work with pathology, which is critical for appropriate selection of tissues, particularly when you work with discarded material. Pathology is the department that can determine what's discarded and what's not discarded, right? And also to perform histopathology that then can inform downstream analysis. So doing that, this is an example of what we do with samples at HSS, right? So we've been doing a lot of cellular and molecular analysis in synovial tissues from patients with osteoarthritis. We've been using tissues for bulk RNA sequencing to identify changes in gene expression. We've been using tissues for single cell analysis, so cryopreserved tissues. We take cells and then we do single cell RNA sequencing. And we've been using Xenium, form of spatial transcriptomics, to then look at those changes in gene expression, those molecular signatures within the tissue context. And we've been also working with pair clinical data sets. From each sample, we have data from that patient so we can get phenotypic information. And we've been doing is integrating the molecular and clinical data sets to get clinically relevant molecular information, right? Associated with joint damage, which it can be structural or pain phenotypes when we are dealing with patient-reported outcomes. And what I thought it was important to highlight here is that I would recommend that people aim to do multimodal analysis, use tissues for different purposes so you can validate things internally, link them to clinical data sets so it doesn't become kind of a technical exercise. You have that clinical relevance, develop robust computational pipelines, which seems naive, but is like very time consuming and is not trivial. And finally, one thing that is very important is that if possible, try to replicate it with independent cohorts, right? Because that you never know whether you're introducing an artifact in your data set just because something is happening within your institution or your biorepository. And I think that was my last slide. This is, again, to acknowledge all the colleagues participating in this type of efforts and the funding that we've been using. Thanks so much for listening.
Great, thank you. Miguel, that's perfect. That sets the stage perfectly as a nice overview. Next, we'll hear from individuals at Cleveland Clinic, from our Cleveland Clinic team, both Kathy Derwin and Eric Ricchetti, who have tremendous expertise in the shoulder. And they'll talk to us about how they leverage their institutional biorepository. Briefly, Kathy Derwin, probably well known to everyone here, the Vice Chair in the Department of Biomedical Engineering at the Lerner Research Institute of Cleveland Clinic and Director of Musculoskeletal Research Center. And then Eric Ricchetti, an accomplished shoulder surgeon who is associate professor at Cleveland Clinic, and he directs the Shoulder Center as well as the Shoulder and Elbow Surgery Fellowship Program. So please go ahead.
Sorry.
Is the swap screen thing?
No, I just need to unmute my microphone. Very good. Hi, thanks for
there we go.
inviting us. Can you hear me okay, Scott?
Great, perfect.
Yeah, so thanks for inviting us to present at this webinar, sharing our experience with the Cleveland Clinic Biorepository. This is a institutional or enterprise-wide infrastructure that not only the orthopedic and rheumatology folks can take advantage of, but anyone at Cleveland Clinic can use. And so I'm going to kind of explain the way the machine works and the way that ortho and rheumatology have taken advantage of this for saving specimens for research. So back in 2021, this group of people, which includes Eric and myself, as well as Dr. Nico Puzzi, who's a shoulder, adult reconstruction surgeon, Elaine Husney, who's a rheumatologist, and Sunil Apte, who's one of my colleagues in orthopedic research, we put together a proposal to be able to collect orthopedic surgical samples and use the infrastructure of our Cleveland Clinic Biorepository for sample collection and storage. And so this mechanism that the Cleveland Clinic has is set up to support collection of surgical samples that are basically discarded samples. And this is then coming from surgical cases. And in this case, you define the samples you want to collect, the tissues, the fluids, the blood. And I'll show you how the kits are created and the samples are collected and stored for us. So this group of people wrote a proposal essentially to store discarded samples from patients. We defined two cohorts, primary knee and primary shoulder arthroplasty patients. And the workflow goes like this. Patients are consented using a universal consent in Epic. It's used for all patients, giving consent for use of their storage of their samples in the biorepository. The biorepository makes kits and gets them to the ORs for sample patients who have been consented. Residual blood in the case of orthopedic patients is not coming from the day of surgery procedures. So these samples for residual blood have to be collected from the outpatient labs from pre-surgical testing if they exist. All samples, no matter where the surgery happens, are then transported to our main campus using a transport service, and our biorepository team within anatomic pathology procures samples, separates the samples that go to path and the samples that go to the BioR, and then they're prepared and stored for future research. So the way this works from a practical mechanistic point is that if Eric identifies a patient, he's taking them to surgery for primary shoulder arthroplasty, asks them if they'd like to consent to have their discarded tissues and fluids put into the biorepository. That's an electronic consent that's entered directly into Epic. And again, these are just discarded samples from surgical procedures. That consent is then documented in the EHR, but that triggers the surgical schedule and the biorepository to ensure we have kits present for that case. Wherever those surgeries are going to happen, the samples get collected, and then they're later can be phenotyped because they're identified with a certain specific patient and MRN. It's important to also say, though, that patients who are consenting for their tissues to go into our biorepository can be co-enrolled. So if I have a prospective study that I'm doing in rotator cuff patients, that's not a good example, in shoulder arthroplasty patients, and we want to put their discarded tissues in the biorepository, we can co-enroll them for research. And this infrastructure can be used for someone doing a prospective research study. So it's a pretty broad infrastructure for us that the enterprise has built for our use. So these are the samples that we collect for shoulders. This is primary shoulder arthroplasty. So we collect a humeral head, piece sample, a joint capsule, a synovium. These samples go through surgical pathology. They take and divide the samples. Half go to biorepository, half go to them for pathologic review. We also get discarded blood, as I said, from preoperative testing, and that goes directly to the biorepository. And then there are some samples that we also collect, but Path isn't interested in them, so we collect discarded synovial fluid, biceps tendon, and shoulder labrum. So all of these samples collectively for a patient are put into a kit, and they go and get transported for storage into the biorepository. Just for completeness, we're also doing this with knees. And again, we have kind of equivalent, the analogs of the same tissues for shoulder. We get femoral condyles, tibial plateaus, that's bone and cartilage, and synovium, that goes through pathology. And then there are some other discarded tissues that are collected, synovial fluid, meniscus, fat pad, both suprapatellar and infrapatellar, as well as any ACL remnant. So this is what the knee collection kit looks like. These samples then arrive in anatomic pathology. If they're coming in from the main campus, we can actually get fresh tissues because the time is such that they can be transported quickly. If they're coming from one of our regional sites, they're coming in fixed, the tissues are. We always get our synovial fluid refrigerated immediately, no matter where it's collected. So that's coming in, not frozen. It gets aliquoted and stored. And if there's any blood that comes in, that gets spun down in serum and plasma gets stored. We track samples through software. LabVantage is the software that we use. A unique ID is assigned to every sample, allows tracking and traceability. And then we store our samples in a building that was built specifically for our enterprise biorepository. It's 25,000 square foot freezer farm, essentially, and all of the Cleveland Clinic investigators who have cohorts in the biorepository are having their samples stored. It's a huge library of samples, all barcoded for subsequent retrieval. So also we are in partnership with Azenta Life Sciences in sort of setting up and establishing the annotation and storage for the samples. So with that, I'm going to give the slides over to Eric for him to kind of tell you some added things about our biorepositories and samples we've collected so far.
Thanks, Kathy, and thanks, Scott and Peter, for allowing us to present this. So you can see what we've done to date. Kathy alluded to we were awarded the opportunity to start this in 2021 and spent the first year to year and a half building our protocols, building our SOPs. And over the last couple of years, you can see the volumes of samples we've been able to collect, both in primary knee and primary shoulder arthroplasty. And you can see that we, as Kathy alluded to, we've got the ability to collect these samples at the main hospital, but also in the region. And honestly, the region's been a source of more samples because we do a lot of our primary cases in the region. You'll notice the blood samples have a lower collection compared to the tissues, as there's been some challenges we're working through in terms of accessing blood from the outpatient labs compared to the tissue samples we can get immediately from the OR. You can click next. And so you can see the breakdown of samples by surgeon. There's 30 samples, 30 surgeons that have contributed to the biorepository. But like a lot of these things, there's a core group of surgeons that have donated most of these samples. There's been 4 primary knee surgeons, 3 primary shoulder surgeons that have contributed almost 90% of the samples. And then, as Miguel was alluding to in his talk, the power in these tissues is to be able to link it to other clinical and phenotypic data. So we're doing that right now and building these linkages through the EMR, which includes the path reports. Kathy alluded to the fact that our pathologists get the bone and synovial samples for reading. We also have robust imaging data preoperatively on all these patients with X-ray and CT. And then we have a large outcomes database that's been built specifically in our Department of Orthopedic Surgery called the Outcomes Measurement Evaluation System. This is a REDCap database that's been around for 10 years, collects all of our key elective orthopedic procedures and collects both preoperative data that includes demographics, patient-reported outcome measures, and intraoperative surgical details, as well as 1-year postoperative patient-reported outcome measures. And this system has been very robust and supported by operational dollars from our department. And you can see our preoperative data is collected at a more than 90% rate, and our 1-year data is collected at about a 75% rate. This data now is also being used for our CMS reporting for primary hip and knee arthroplasty. Next slide. So what's the future? I showed that slide earlier. We've got a robust biorepository of samples from primary shoulder and knee arthroplasty. These are primarily osteoarthritis samples, so we're trying to enrich the biorepository for less frequent diagnoses now, including inflammatory arthritis diagnoses and post-traumatic arthritis diagnoses. And then we're also trying to bring in other surgical procedures. We're going to start collecting from total hip arthroplasty, as well as some non-arthroplasty surgeries, including rotator cuff repair and ACL surgery. With rotator cuff repair and ACL, we're focused just on collecting synovial samples because these are more arthroscopic procedures. And then we're now moving into the analysis stage of our biorepository. We've collected these large number of samples and looking at how to develop projects to analyze them with proteomics, degradomics, our histopathology, and other omics analyses that we're working through right now. Next slide. And again, Miguel alluded to this as well. How does the structure of this work? There's a biorepository governance committee that establishes the rules around how these samples can be shared. Kathy alluded to there's a general consent that for patients to donate the samples, but if a particular research study is being performed, that requires a separate research proposal and a separate IRB approval. And there's a biorepository steering committee, as well as the PI that collected the initial samples, that has to approve a particular project and approve the IRB. And if a project's approved, there's nominal costs for the investigator to remove the samples from the biorepository. There's a dashboard that's been created that allows investigators to look at what samples are available, to see if there's samples to be able to ask their research questions. And these samples also have the ability to be used externally. These can be de-identified, and again, through research protocols and IRB approval, they can be shared either with a DUA if it's just specifically de-identified data or a materials transfer agreement if it's the actual samples. Next slide. So what have the challenges been? I showed the slide earlier about surgeon engagement. Not all of our surgeons are collecting samples in every case, but we've had a core group of surgeons that have been highly invested in this and have allowed us to build a really robust sample. Blood recovery has been a challenge. Kathy alluded to this because it occurs in the outpatient setting before surgery. We're still trying to work through the best way to capture blood at the same level that we can capture our intraoperative tissue samples. Our regional sites don't allow for fresh tissue collection. Kathy alluded to this because of the transfer time. And then we're working through our linkages with the clinical data so that we can verify the exact diagnosis in all of these cases. These cases are stored in the biorepository, but we want them to be able to be pulled out and know exactly that the patient had a diagnosis of osteoarthritis or rheumatoid arthritis, psoriatic arthritis, so that they can be used easier for analysis. Next slide. And then finally, we've talked about this in both talks, the impact that this can have. Building this well collected and well curated library of biomarkers and biotissue specimens allows us to be able to integrate this data with our clinical data and perform, high-powered translational research. And you can see the large numbers of samples you can get from an infrastructure like this to be able to look at large data from both a biosample standpoint and a clinical standpoint. And the future for us, as I alluded to, is the ability to expand this to other orthopedic cohorts that are important to study. Next slide. So thank you for the time, and we can move on to our next talk. Appreciate it.
That's great. Thank you. I got that's there's two talks give a good example of the need for an organized, well thought out workflow to do this, and you get a sense of the resources I think required: human, technical, financial. Important points here about governance and who owns the data, who controls the data, steering committee. So our third talk here, my colleague Shane Shapiro. Shane is at the Mayo Clinic in Jacksonville, Florida, and has been part of the Biologics Association with us since the outset. Shane is the medical director of the Mayo Clinic Center for Regenerative Medicine. His specialty is non-surgical orthopedics. He's an associate professor in orthopedic surgery at Mayo Clinic. And Shane was going to talk to us on gathering orthobiologic real-world evidence using registries and biorepositories. So thanks, Shane.
Yeah, thank you guys for having me. And I think what I'll just try and do is tie it all together and do my best not to repeat some of the operational components of this, but talk about one very specific example of how we are presently using biorepositories to gather real-world evidence. So I think most of us are probably aware of how challenging it can be to bring a new product to market, and this shows the phases of conventional drug discovery, bringing usually a small molecule, but also a biologic to market if it's intended to be used in the diagnosis, cure, mitigation, treatment, or prevention of disease. Then we consider those products drugs, and yet for novel biologics and orthobiologics, even as simple as platelet-rich plasma can be considered a biologic drug. These are incredibly expensive to develop and characterize and subsequently bring to market, upwards of $1 billion when looking at a study of 355 new drugs that the FDA considers as biologics and that the FDA had previously given approval to. And so for that reason, what we're commonly doing in the orthobiologic space, at least in clinical practice at present, is we're taking an easier pathway to bring products to our patients, which is using 510K cleared devices. So when that happens, these products, we're allowed to use these as part of our medical practice, but they certainly have not been approved for use. And so when we think of how we can bring more treatments, whether they be product or procedures, to our patients in the regenerative medicine roadmap, we have to have a hybrid approach where we're bringing some of what we know about conventional drug discovery, but also marrying it with traditional surgical innovation. And the reason we have to do that is there may, in fact, not be an FDA approval process for these first generation orthobiologics. So when we use platelet-rich plasma, or we use bone marrow, or even adipose tissue in our practice, as I mentioned, these are off-label uses of 510(k) cleared medical devices. So the devices have been cleared, they're not approved, and then this is allowable for use in our medical practice. But again, the resulting product is not approved for use. So what we find here is that the practitioners, the providers, become not only product developers and manufacturers, but we also have to be the evaluator of that technology. And this presents incredible challenges. Many of us have already gone through some of these. If we're using these products in practice, you have an idea, you know how to make something like platelet-rich plasma. You develop an SOP. We have policies that surround that. We're actually manufacturing the product, and of course, the simple part for most of us is we know how to deliver that product to the patient, whether it be an interventional strategy or a surgical procedure. There's basic clinical guidelines in terms of how we have to handle those products, and then the new approaches that we have to take include operational issues, insurance coverage, billing and coding, and of course, finally proving that the product or the procedure that we're doing actually works for our patients' conditions. And so that's really where the biorepositories and registry developments come into place. So to that mutual end, in November of 2022, the American Academy of Orthopedic Surgeons and the Biologic Association convened a symposium, a gathering in Washington, D.C., and we invited the FDA as well as industry and other musculoskeletal stakeholders in this space to join us to study how we gather real-world evidence. And so that publication that I just showed you has recently been published in the Journal of the American Academy of Orthopedic Surgeons, and it talks about many of the concepts that we've been speaking about tonight, not only for biorepositories, but also for biologic registries. And many of these issues have already been mentioned, so I'm not going to repeat them, only to highlight that in that publication, it should serve as a mini playbook for a number of the concepts that we've reviewed tonight, and then also talk about what we might be able to use them for, as well as some other nuances to generating real-world evidence. The essential elements we've discussed about collection and processing, storage and distribution, but then other things such as the chain of custody, which is crucial to the success of these investigations, but also designing and configuring what questions we're going to ask even before we create the biorepository, so that when we do ask those questions of the biorepository, we're set up for success. Figure from the publication, very similar to what we've seen already, talking about informed consent, sample collection, how we process, bank, and store. And I would like to highlight, since we've got a number of different team members on the webinar tonight, the role of the clinical research coordinator, who's the lifeblood of a research project like this, that individual is often communicating with patients, sometimes involved with informed consent, all the procedures that might be not just for the actual intervention or surgery, but also sample collection, and then making making sure that we schedule the follow-up patient-reported outcome measures, and sometimes even transporting the sample to our biorepository. The laboratory information management system has been mentioned already, and this is crucial for our colleagues that are running the biorepository. And then disaster preparedness of we've perhaps some of us have heard these horror stories about situations where samples were lost due to certain disasters. And for the amount of work that we've all put into standing up these biorepositories, and the work that our patients have volunteered on behalf of these projects, we simply have to prevent those disasters from happening. It's crucial that if you're going to have a biorepository and you're going to collect patient-reported outcome measures in a registry, that we link those two together. And so our IT colleagues to help us with clinical informatics so that we can study outcomes that are linked to those samples. That's crucial as well. So thanks very much. I encourage you to look up the paper as a result of that conference that included a number of experts in the field, and if you're interested in more about that.
Thank you, Shane. You make a very important point about the critical importance of our research assistants and research coordinators. They are the lifeblood. And I think one of the challenges is integrating this type of thing into the busy clinical workflow. So we're clinicians, we're surgeons, you're in the operating room, you're seeing patients. The reality is you need those individuals to really help you, procure specimens, get the good samples in a timely fashion, but also just and not interrupt, the busy clinical workflow. I think that's the way you really get research done and incorporate it into your day-to-day, workflow. So we have a little time for some discussion. I thought I'd pick out some of the high points that came out of that, and important issues that I think and things and challenges that we've addressed here at HSS. And one, Kathy and Eric at Cleveland Clinic, you both mentioned getting specimens from your regional sites. What are the challenges, or how do you do that? Do you have a courier service? How do you actually get the specimens from, a satellite out in suburbia back to the main hospital?
Yeah, so we do have a courier service that the biorepository coordinates. It's not something that Eric needs to coordinate. Eric needs to, in his busy OR, has a kit waiting for him. He needs to take the time to take the samples. And I don't know, actually, frankly, if Eric cuts them himself and puts them in the bags, but somebody comes to his OR and picks up those samples in the region or on the main campus, and then worries about their transport under appropriate conditions back to the main campus pathology. So if it's a surgery that's on our main campus, they get walked there. If it's a surgery that's at a regional site, they go downstairs to pathology, and there's a big bin in a refrigerator in the path lab at that site where all the kit's coming in. So if the knee surgeons are bringing in 15 cases that day, and the shoulder surgeons are bringing in 7 cases that day,
Yeah.
at the end of that day, all those kits get transported, well, actually twice a day. There's a courier service running from every regional site back to the main campus. But that's why, although they're refrigerated, the fresh tissue samples really couldn't get back in time to flash freeze, to freeze them and get them in the freezer. So the tissue samples are going into but formalin immediately. The synovial
Right.
fluid stays at 4 degrees C, and then they get transported at 4 degrees C and maintained. Synovial fluid gets aliquoted and stored. The samples are already in formalin, and that's how the regional site transport works. Twice a day, all our regional
Yeah.
sites integrated courier service. And the other point to make is that anybody who establishes a cohort with our biorepository team, they know what hospitals that involves. So
Mhm.
that's we don't have couriers running to all 14 Northeast Ohio hospitals at the moment, because I think we only have samples being collected at 5 or 6 regional hospitals. So that
Right.
courier path, and they might be collecting cardiovascular samples in kits too for the biorepository. So they're making a run that
Mm.
just picks up the big bin and brings it back to anatomic pathology twice a day with anything that has arrived in the morning and the end of the day.
That's an interesting point. Yeah, you're a big institution. You have more than just orthopedics. So we're true. I'm
Yeah.
sure you may have specimens.
Yeah,
To
and
Miguel,
Scott,
to
Well,
I'm sorry, go
Scott,
ahead.
to your point of, and to your point, Kathy alluded to about, incorporating it into the surgical workflow. When we built the sample protocol, me and the other shoulder surgeons said, how are we doing this in the normal way we do a case? So all our samples get taken out the way we would normally resect them when putting a joint replacement in. We
Yep.
give them to the surgical tech. The surgical tech has the containers right there to put them in, and there's no extra work. And I think that's been one of the keys to our success. We're not doing anything extra, so it's
Yep.
not like the surgeon doesn't feel like they're doing some extra research study. It's just it's the normal clinical workflow.
Yeah, that's an important point. Having not just the surgeon, but the nurses, the surgical technicians, they're used to it. They know it's not like, what do I do? What is this specimen? They know that's like it becomes turnkey, and that's really important to establish. And if you have to do a couple, they get used to it. So, Miguel, me can comment to follow up on Kathy's points about the specimens coming to the lab. So, the question I ask is, you're going to allocate piece for formal, for histology, maybe some tissue for flow cytometry, maybe some for single cell analysis. What are the kind of challenges, or how do you divide that tissue up, and timing? I mean, some of those things need to be done pretty quickly, right?
Yeah, no, and what I discussed, we were only dealing with the main campus, right? So it truly is across the street. Pathology department and the research building is like 5 minute walk, right? And so the limitation is tissue size, because the workflow is that the surgical material will go to the pathology department. Pathology will select tissues for diagnosis, and then they will select tissues for research, right? And sometimes, ideally, we want to have tissues for everything: paraffin, RNA later, and
Yeah.
cryostore. But it's not always possible depending on tissue size. So we've been kind of making hierarchies, right? Depending on some studies, the priority will be single cell analysis, so it will be cryostore, and then you go from there. And recently, we've been using paraffin for everything. One of the advantages of paraffin is that you can do single nuclei in RNA sequencing, so you can use paraffin to take nuclei and do
Yeah.
similar analysis that you will do with single cell. And that kind of bypasses, so that there are limitations, but bypasses some of those challenges. But the limitation, aside from the timing, right, is the tissue size, right? And then
Yep.
we out of the need, similar to what Catherine discussed, we collect. So I was focusing, or the slides I present, the cartoons I present were primarily synovial tissues, but we collect cartilage, we collect bone, we collect different tissues, and they all have their own kind of unique limitations.
Yeah. Actually, that point about tissue size, an important point. Like Kathy mentioned, how Cleveland Clinic and other places, you can use even our biggest for normally discarded tissues. But Shane, you can comment. What about some, if it's a non-surgical patient, these aren't discarded tissues. What is the IRB status, and how do you have an IRB for each different joint or study or tissue?
Yeah, well, we definitely need IRB approval to study this. And what we've tried to do in consultation with our IRB is just get a broad IRB that allows us to study synovial fluid, blood, fat tissue, and bone marrow. Really, anything that would have been medical waste that would
Uh-huh.
have been thrown away if we keep it de-identified, we're allowed to collect it and store it. And for our purposes, the broad IRB is for studying orthobiologics, or for orthobiologic science. Now, we've been able to expand that IRB, or replicate that IRB for some more specific approaches for some of my surgical colleagues when they have a specific question that they want to ask regarding tissues from the operating room. Sometimes we've used that broad umbrella IRB, and sometimes we've just written another one, because if you're de-identifying the tissue, it's a minimal risk protocol for patients, and rather simple to accomplish.
Yeah. Yeah. Eric, if you're in the OR as a shoulder surgeon, if you're providing just the normally discarded tissue, that's easy or easier. What about taking a sample, say, a piece of rotator cuff tendon that normally you do to breed the edge of the tendon, but separate consent to take a 3 millimeter by 3 millimeter sample of tissue? And are you doing that? And what challenges, you have patients that refuse and, to do that or enrollment?
It's interesting you bring that up because when we've been discussing the protocols now because we're trying to move to arthroscopic
Yeah.
procedures like rotator cuff repair, we've had prospective cohorts that are true funded research studies where we've taken research samples like what you're talking about. When we made the decision to try to build rotator cuff repair into the biorepository, we talked a lot about is it realistic to take additional samples like that? Again, getting back to what's going to be reliable from the normal surgical workflow if you're asking a larger group of surgeons to get these samples. So, we chose for rotator cuff repair ACL to leave it at synovial fluid because that's what we think
Uh-huh.
can be reliably obtained on a broad, larger scale of patients. Whereas, getting at tendon stump, bursal tissue, that's really we've left for a specific study question where it's a more select group of surgeons who are,
Yeah.
invested in getting those. So I think that's part of the discussions we've had with all this stuff is what if we really want the whole department to do this, what do we think the average surgeon's going to get versus if we're doing our own research study, what do we care the most about for a particular research question?
Yeah, I think you make an important point about surgeon engagement as well. I mean, like anything, there's going to be a cadre of surgeons that are engaged and interested, and others that aren't. And that's fine. I think you allocate your resources to those that are involved. So, like your courier service, the 6 or 8 places that are going to provide specimens. You don't need to go to the other 10,
Yep.
right, or something. It's um, Kathy, you're a director. You're leadership position. How do you fund all this?
Yeah, well, there's really two ways. One is the fact that we have an institution that has put a lot of money into an
Right.
infrastructure. And frankly, orthopedics, it wasn't built for orthopedics. It was built for cardiovascular, cancer, and neuro. Okay,
Yeah.
so they had this set up and established and running. We were the fourth group who got an opportunity to put samples into this biorepository. And there's a COVID cohort. So there's a lot of
Hmm.
samples in our biorepository now from a lot of patients that are not getting orthopedic procedures. So that's number one. We had an institution who said enterprise-wide, we want to create a machine to collect surgical samples that are just, going in the garbage can. So I didn't fund that. We're taking advantage of that, and we're taking advantage of resources that are really, coming from other places. But the second thing is this is now built. And so if I'm writing a prospective study that is a research study I care about in rotator cuff or shoulder arthroplasty, whatever, I have this resource that I can use and I can put money in a budget to use this same resource to make kits for me to go into an OR for a prospective research study and collect my samples and get them back and go through the same flow and get coded and go in the biorepository storage as a prospective research protocol. So now I'm helping to fund
Uh-huh.
that study. So there's sort of two sources of revenue, and ideally, these samples are going to generate revenue from research. We're going to write a grant for, about 800 shoulder samples now, right? And that should generate resources that would come back to the institution. So I mean, I think it always takes an investment with research, right, Scott? I
Yeah.
mean, you got to put money down first, and then you hope to recover something from someone who has a vision to say, let's spend money here. And so we're fortunate to be at a place where that investment has been made.
Agree. Yeah, you need an institution that's supportive. And so if you're in a smaller group or private practice, there's ways to get involved. Maybe you link up or collaborate with individuals at an institution that has some of this infrastructure to make this happen. I was interested, you mentioned this group, the Zenta. Um, is that a corporate sponsor? I mean, do they help fund your effort and
No, you know what? I was trying to look that up in the last minute because I know they sponsor the storage part of it. I know they're considered sponsors of the storage, like the building that we have as our biorepository. We call it a partnership with Azenta Life Sciences. So
Okay.
exactly what role they have in financially, I frankly don't know that, but
All right.
it's considered we refer to it as a partnership with Azenta Life Sciences.
Yeah, and the kind
And
of reason I ask is one of the challenges with these, as you said, okay, you've got this registry, you've built it, governance. Uh,
yeah.
who and how, who can access the specimens, who can use the specimens, and if you had an industry partner, yeah, do they have some, yeah, some right to the specimens? I mean, those are sticky
Yeah,
questions
no,
potentially.
there's no industry partnership with ownership to the samples. The samples
Good.
are,
Yeah.
are purely Cleveland Clinic, purely governed by Cleveland Clinic.
Yeah. We're almost out of time, but Miguel, you made an important point about REDCap for the clinical data. We use open specimen HSS. I think Kathy mentioned, and Eric, you Lab Vantage. Point is, using these digital tools to collect clinical data and tracking specimens. I think, Shane, you mentioned the LIMS, Laboratory Info Management System. I guess these are all kind of similar, but I think, just your comments, Miguel, you've used open specimen. Has that been very helpful? And is there ways to improve our ability, use these digital tools to track specimens?
Yeah, it's not intuitive, right? So it actually requires a lot of work and institutional investment in terms of money. Those tools, they are not cheap, right? And every time that you need to fix something or implement something, you need to pay for it. But it's been really helpful because it truly is kind of a cloud-based system. So everything is like safe, it's stored there. HIPAA compliant, and then they are transferable, right? When someone leaves, you can kind of keep track of the sample story. So it's an investment. It's a good investment, but then it truly is kind of people need to be patient, right, with them. Like whenever you are implementing any type of software or new tool, you need to
Yeah.
kind of get used to it. Yeah.
Yeah, well, all three institutions, Mayo, Cleveland Clinic, HSS, we're all using different systems, but we're using systems. You clearly, the old days of, writing down putting a label in a, little notebook and writing, writing down what the specimen was, we're kind of beyond that. So,
I mean, it's interesting for us because we're working through trying to link all this data now from different sources. And one of the challenges we've had from an IRB standpoint is separate registries you can't just link together from an IRB standpoint.
yeah,
That patient report outcome measurement registry we have that's within orthopedics, that's a registry approved database, and then our biorepository is a registry approved database. And to this point, our IRB has not allowed us to completely link those. They can only be linked through specific research studies.
I see.
And so, I think ideally we'd all like to be able to say, well, if I look at this one patient, I can see everything in that patient all at once, their biospecimens, their clinical data, their x-ray data. But right now, there's, governance, IRB,
Yeah,
legal things related to that being able to be done. So it'll be interesting to see how that works out.
yeah, those are
So you
important
can,
points. Go ahead,
oh,
please.
no, I just had a question. So you can only link it retrospectively once you have all the data, and then you can link both of them, right?
Yeah, so like our biospecimens right now, I can't just
Mhm.
automatically get all of the proms, demographic data, x-ray data linked to that. So I have to write a specific research study to bring it in and then do that study, but it doesn't keep linking in real time. So that's, one of the things that we're not allowed to do yet. I don't know if Kathy, I don't know if you have anything else to add to that, but yeah.
No, it's a good point. Registries, at least in our place, are there's a universal consent to sort of say you'll give your data to be stored for future research.
Yeah.
And that's the way
And
the consent is simple on that end for the patient. But the
I
IRB
think
then requires any use of that information has to have a protocol with a real research question
Yeah,
associated with it.
I
same
think the
here.
issue there is that you have two de-identification keys that are independent from each other. So in order to link them, you need to have separate IRB.
Yeah. Yep.
Well, to link them practically isn't that hard. I mean, when the
Mhm.
biosamples come in, everybody's got it's just this is not de-identified data. I mean, we have the identifying characteristics so that we can do the linking. The linking isn't
Yeah, you need it.
practically very hard to do. It's just logistically has not been set up for smooth looking at all these different sources of data yet. I mean, I think that's obviously where the institution will be going. These things will be all linked together, but we aren't there yet. The other point that's worth noting, and is this that because this is an enterprise-wide biorepository, not just for orthopedics, if I want to do a research study to look at, or Eric, we have a real case, a cardiovascular surgeon wants to look and see, is very interested in connective tissues, is whether there's amyloid present. And he wants to come and see if he can use our biceps tendons, right? And do staining. So he can go to the dashboard in his office and see if there's any tendons in the biorepository. Find the investigator with whom they're connected and either reach to that investigator directly or just write a proposal to the biorepository who will then reach to the investigators. So that's the nice thing about doing this sort of enterprise wide is you now can ask questions that aren't solely limited to orthopedic cohorts. So it's just an added advantage. We don't know how to take advantage of it yet, but it will be something that'll have a lot of power, I think.
That's great points. I mean, this brings up the, HIPAA and data privacy and the lawyers are always involved and lawyers are lawyers. But this has been helpful. Both two big time institutions, Mayo Clinic and Cleveland Clinic, and we learn a lot from each other and
Yeah.
share, challenges and what works and what doesn't work as we move forward. Eventually, we should put together a summary that can be published to help. But anyway, if there aren't any further questions or comments, we'll
Yeah,
let
yeah,
everybody get on with their evening.
yeah. I just have a very quick question. Very curious about that. So, very nice talks. I learned a lot. You have amazing infrastructure. So once you put all the time and effort to collect the specimen and get all the data from the patient, what part fails most often? Is it a chain of custody or labeling or staffing, transport? I'm just curious, like to give people some advice what to avoid or what to watch for. And it's a question for any all of you.
I'll make one brief comment. For us, it's from any place. I think it's the clinical data, the follow-up clinical data side.
Mhm.
And Cleveland Clinic's got this phenomenal OME program. Your follow-up's crazy. It's impressive. You can make some comments, either Shane or Eric or Kathy.
Yeah, I mean, I agree, and to your point, Scott. So our clinical database, Kurt Spindler really built that, and
Yep.
that
Yeah.
was, as Kathy has alluded to, that was departmental resources where the department committed to funding it. And the post-operative data collection comes from paid research assistants that their sole job is to collect that data. And it's done all through digital linkages that patients fill out rather than trying to do in-person contact points in the office. And interestingly, and sort of we've brought this up, sort of the downstream positives of building something like this. Now that there's a requirement for CMS reporting on hip and knee arthroplasty,
Yeah.
there's a requirement for PROMS reporting at 1 year on hip and knee arthroplasty. The funding for OME is now in quality because this is a quality measure now. It's
Yeah.
not just a research measure. So you can see the benefits if you support something like this. So we've actually gotten more dollars and resources to support it because it's part of quality now.
Yep. Same here. And that's if there's other stakeholders, they can help share the costs. Other groups have skin in the game or need to. Yeah, that's an important point.
I think the other thing when it comes to, and rather than being kind of an issue with specific biorepositories, is an issue with comparison across repositories or studies, right? Because everybody has their own kind of, particularly for samples, right? But I think it applies to data. Everybody has their own favorite protocol, their own favorite kind of preservative and whatnot. And then when you try to integrate data sets, you realize that the samples were processed differently. You are introducing that type of nuance, and that kind of complicates quite a lot of the downstream analysis, right? So I think that there are several initiatives trying to harmonize protocols, but I don't know how they are going to work because even that's tricky within a small institution. I can only imagine like across laboratories and then institutions, right? But I think that I would pay attention to that, the type of protocols that people are using, and maybe rely on protocols that they have been published so you can kind of compare data sets.
Yeah, I guess your question, Peter, about where can it fail? I mean, you've got procuring the specimen, processing it, getting it to the lab, storing it. All we can screw it up anywhere along the chain, I guess, or at least introduce variations or nuances that are different from one institution to
But from
another.
your experience, which one would you say is the most common, or what to focus on, change SOP or hire better staff, or what would be a recommendation?
From our case, it was processing, right?
Yeah.
Especially when you are dealing with things like blood. Some people are interested in PBMCs, like blood cells, right? And different laboratories were using different kits that they do the same thing, but they stress cells differently. So that's a source of variability. And then like rushing, trying to kind of do things without optimizing them. So, it's like you have the study, you have the money, you want to collect tissues, but you don't want to spend time optimizing the protocol, and that tends to be kind of a recipe for disaster, right? So the initial optimization step, if you have good coordination with surgery and surgeons, they tend to be engaged in that, and then the personnel transferring samples are well trained. Those two steps are relatively straightforward. Fingers crossed or touching wood or whatever. but I think the processing, the technique involved in processing, homogenizing that part, right?
Maybe one last thought on that, Miguel, just having ideally the same person do it, not have four different people do it on different days. If you can, establish, because there's variability within individuals, and ideally you have an individual or individuals, limited number who become experienced and doing it in a standardized, reproducible way.
Yeah, we have a team, I think there's 4, who have an entire bench in pathology, and it's the BioR bench, and that's all they do is simple
Yeah.
kits come in, they divide, it goes to path, it goes to them, they process. I mean, they're set up to, I mean, it doesn't mean there's not variability, but that's the way to try to
Sure.
gain consistency. But across institutions is another question altogether, We were,
Yes.
should we use purple tubes? Should we use yellow gold tubes? Should we put this at 4? I mean, right. And
Yeah, right.
we know what we did, but did we try to harmonize with others? The answer is not really. Maybe with others in our own institution who are already doing it. Like, what do they do? Okay, we'll do the same thing, kind of thing. But I think
Good point.
you bring up a good point, Miguel, to try to publish. And we've never published, so it might be an opportunity, in the field to try to create some harmonized protocols for which tissues to recover, what fluids or what to store them in, what solutions to store them in, what temperatures, time to recover, those kinds
Yes.
of things. I mean that could be done,
Yep.
and should
That
be
might be
done,
very helpful.
honestly. Yeah, I wrote that note down. I learned a
Get a
lot of
working
things.
group. Yeah, it'd be
Yeah,
good to get a working group to really say,
yeah,
here's, group of eight,
yeah,
8 or 10 institutions that come to some consensus.
yeah,
Not a bad thought. That'd be a good service to the field.
yeah. It would be.
Yeah.
All right. Well, it's 9:15 here in New York. Something obvious, but this is great. I learned a lot from you all. This is very helpful. So thank you so much. Hopefully our audience out there learned something as well.
Thank you.
That will sign off.
Thank you.
Good
Appreciate it.
night.
Good night, all.
Night.
Take care.
Thank you.
Good night.
Thank you.